Good afternoon, everyone, and welcome to the GOJO 2021 Symposium at APIC. We are thrilled that you're here with us today, and we know that the past 18 months have been incredibly difficult for the infection prevention community, so we thank you for all of your tireless efforts and dedication. And although we had hoped to see you in person, we're really happy that we can still meet virtually as a community to share information, education, and ideas. I am very excited to have with us today Matt Austin, who is with the Leapfrog group, and also Sylvia Garcia-Houchins from the Joint Commission. And today, Matt and Sylvia will be sharing their respective organizations' perspective on hand hygiene as they strive to move the dial forward in patient safety in healthcare facilities. As a reminder, these are our learning objectives for today's session. Just a few housekeeping items. Within 48 hours of attending this symposium, you will receive an email with instructions for how to claim your continuing education credits. I also want to point out that you can feel free to ask questions throughout the presentation with the chat button. And at the end of the session, we will answer as many audience questions as time allows. So without further ado, I would like to turn the virtual podium over to Matt Austin and welcome Matt. Thank you.
Megan, thank you so much, and thank you to GOJO for the invitation to join you all today to talk a little bit about the Leapfrog group's and hygiene standard. Very much appreciated, and good afternoon and good morning to all of you. As Megan made mention, I'm Matt Austin. I'm a faculty member at the Johns Hopkins Armstrong Institute for Patient Safety and Quality. And I'm going to talk a little bit today about the Leapfrog group's hand hygiene standard, and specifically the whats and the whys of those standards. Before we move on to the next slide, I just want to sort of share a little bit of framing for who the Leapfrog group is. The Leapfrog group was founded 21 years ago, back in 2000, by large purchasers of healthcare. These are companies that buy healthcare benefits on behalf of their employees and their employees' beneficiaries. The Leapfrog group really came together in response to the Institute of Medicine's report To Err Is Human, which found that somewhere between 44,000 and 98,000 Americans die in US hospitals each year due to medical mistakes. For these large employers, that translated into real numbers of their employees and their employees' loved ones that were dying in US hospitals. So the Leapfrog group has been around for 21 years, and we're going to talk a little bit about the new hand hygiene standard. So just a little bit about myself before we jump in. As I mentioned, I'm a faculty member at the Johns Hopkins Armstrong Institute for Patient Safety and Quality. I've actually been working with the Leapfrog group for the last 14 years to provide them with scientific guidance around their various measurement activities, the Leapfrog Hospital Survey, the Hospital Safety Grade, and their new Ambulatory Surgery Center. My role with Leapfrog is actually to help synthesize the recommendations of technical experts into the context of Leapfrog's values, mission, and practices. I come from an industrial and systems engineering background. I worked in the airline industry for about 12 years prior to shifting over to healthcare. And my research focus is specifically on performance measurement in healthcare. All right. So why is the Leapfrog group interested in hand hygiene? I'm not sure I need to spend much time on this slide, specifically with this audience. I think you all recognize the importance of hand hygiene. But Leapfrog does remain concerned about infections in healthcare settings and the important role that proper hand hygiene can play in reducing those infections. Infections, result in patient suffering. They increase a length of stay of a patient in a hospital, and there are additional costs associated with healthcare-associated infections. And those costs are ultimately borne by Leapfrog's members, who are healthcare purchasers. Leapfrog was founded on the idea of transparency, that those that are using the healthcare system and those that are paying for the healthcare system have a fundamental right to understand how it's operating. And Leapfrog is interested in understanding publicly how healthcare facilities are doing with hand hygiene. So Leapfrog actually took the initiative to develop a new standard. And so why was there interest in developing a new hand hygiene standard? Well, Leapfrog's actually been measuring hospital practices related to hand hygiene since 2004, and specifically using the National Quality Forum Safe Practices for Better Healthcare. But about 3 years ago, Leapfrog decided that a change was needed. Hospitals had generally topped out on the NQF safe practice. Many hospitals across the nation are reporting 95% compliance with hand hygiene, and yet we're seeing just sort of modest improvements in infection rates. And ultimately, Leapfrog sort of felt like the NQF safe practice wasn't quite getting at the most meaningful elements that could be included to reflect a best practice hand hygiene program. So how did Leapfrog go about developing a new standard? Well, we've pulled together a national expert panel of truly national and international experts in the field of hand hygiene. For those of you who've been in the infection prevention world, I'm sure you'll recognize many of these names. These are individuals who have led the World Health Organization's hand hygiene initiatives. There's folks here who've published significantly and done significant research around hand hygiene. We are incredibly blessed that these 5 individuals have been willing to step up and help guide Leapfrog's efforts around hand hygiene. Certain just important points to note. The expert panel was formed in 2018, and the charge that we gave the expert panel was for them to identify best practices in hand hygiene. All of Leapfrog's expert panelists volunteer their time. They are not paid. We do ask them to complete a disclosure form once every 3 years, and we actually start every expert panel call with verbal disclosures in case there's anything that needs to be raised in the interim. So just try to lay that out there so that folks understand sort of how this is structured. We developed the standard with the expert panel over 8 60 to 90-minute calls, over 2 years. We've had dozens and dozens email exchanges. My point in sharing all that is just to let you know that the panel has spent a lot of time and effort to sort of think through this and to help guide Leapfrog around best practices. And any comments that come in about the standard, we review, we take them to the expert panel. And so we've had a lot of discussion and rediscussion about the elements of the standard. So the expert, let me jump back real quick. Sorry about that. So Leapfrog, expert panel did help Leapfrog identify a set of 5 domains to reflect best practices. The standard that they've helped us develop is adapted from the World Health Organization's hand hygiene self-assessment framework. And I specifically use the word adapted in that it's not necessarily an exact replica. The expert panel, I think appropriate realized that there were certain elements in the WHO framework that perhaps were not necessarily meaningful or applicable to US hospitals. So the one example I can think of is in the WHO framework, there's references to healthcare facilities having access to clean running water. That's something that here in the United States, we're fortunate enough that we can sort of go with the assumption that all facilities have access to clean running water. So the expert panel did walk us through the WHO framework and helped us identify what elements are most important and most relevant for US hospitals. And I'm going to walk you through those 5 domains to talk about what are some of the key elements of each of those domains, and maybe more importantly for you is why we chose to include those elements. So we're going to jump into the 5 domains of the Leapfrog hand hygiene standard. The first domain is a domain that focuses on training and education. And Leapfrog specifically lays out in this domain who needs to be trained, what's the frequency of that training, who should be conducting the training, and what content should be included in the hand hygiene training. Our experience is, this type of information is, pretty standard across most healthcare facilities and has been met with, I think, a lot of acceptance. The element within the training and education domain that has probably been the most controversial is the requirement that all new hire healthcare workers need to demonstrate proper hand hygiene prior to starting work in the hospital or facility. Now, what's interesting is the original proposal was actually to include this element in the culture domain as a way to communicate to new hires that proper hand hygiene is incredibly important to the organization, and that before you go out and care for patients, we want to make sure you know how to wash your hands correctly and properly. Now, the expert panel did recommend that Leapfrog actually move this element over to the training domain, as it does focus on demonstrating a core competency. And Leapfrog has received a number of supportive comments about this element, that simply assuming that staff's original training covered this appropriately is perhaps a flawed assumption. The second domain of the Leapfrog Hospital Standard focuses on infrastructure, and specifically speaks to having the consistent and easy access to the tools that healthcare workers need to properly practice hand hygiene. I won't go through all the elements of this domain, but there are two elements that have received the most attention. The first is having specified locations where alcohol-based hand rubs dispensers should be located, and the requirement to conduct periodic audits of the volume of alcohol-based hand rub that needs to be dispensed. So let's talk about the first one first, the specified locations of the alcohol-based hand rub dispensers. So Leapfrog does actually specify that facilities need to have alcohol-based hand sanitizers located both at the entrance of the patient's room or bed space, as well as inside the patient's room or bed space. Now, studies have shown that the convenient placement of dispensers makes it much more likely that healthcare workers are going to use the hand rub than if the dispenser is geographically inconvenient. So having dispensers at both the entrance and inside the room makes it much more likely that the healthcare worker will comply with proper hand hygiene. Now, regarding the second element of why we ask facilities to conduct periodic audits of the volume of product that's being dispensed from wall-mounted dispensers. Leapfrog's expert panel has actually noted a number of examples where facilities have actually adjusted down the amount of product that's coming out of the dispenser, generally at the complaint of employees who are saying it takes too long for their hands to dry. The concern is that an insufficient amount of product being dispensed could result in employees having unclean hands. And there have been instances noted where there have been infection outbreaks that have been linked back to healthcare workers using dispensers for which not enough product was dispensed. So the concern is just to make sure that what's being dispensed is something that's going to be useful. So the monitoring domain is the third domain of Leapfrog's hand hygiene standard. Leapfrog wants to ensure that facilities are monitoring compliance with hand hygiene in ways that are ethical and unbiased. And to no one's great surprise, this is easily the domain that has generated the largest number of comments. So Leapfrog currently actually recognizes two options for monitoring in its standard: the use of secret observers and the use of electronic compliance monitoring systems. So if a facility chooses to use secret observers, Leapfrog has indicated that a minimum sample size of 200 observations per unit per month is the requirement. Now, we've gotten a fair number of questions of where does that 200 observations per unit per month come from? And this is based on what is needed to accurately observe, i.e. have statistical confidence that a unit's hand hygiene performance actually changed by at least plus or minus 10%. Smaller samples, say 20 or 30 a month, do not provide a large enough sample to actually understand if a unit's hand hygiene performance has actually changed. The 200 as a sample size aligns with the World Health Organization's technical reference manual and also matches what other international hand hygiene programs are doing. Now, Leapfrog does allow facilities to scale down that sample size for smaller units because we recognize it's going to take a longer amount of clock time to collect 200 observations. So Leapfrog does lay out in its survey a table that sort of scales that down based on occupancy. And Leapfrog does offer hospitals the opportunity to earn partial credit if they do 100 observations per unit per quarter. So that's 100 per quarter as opposed to 200 per month. Now, Leapfrog does reward facilities that are using and adopting electronic compliance monitoring systems. Leapfrog actually has 3 concerns with the use of secret observers to monitor hand hygiene compliance that it believes are well addressed by the use of electronic compliance monitoring systems. The first is the ethics of a secret observer watching a healthcare worker not properly do hand hygiene and go into a patient's room, and the ethics of seeing something that shouldn't happen and allowing it to happen. The second is the concern that secret observers actually are collecting a very small fraction of the total possible hand hygiene opportunities. So even with the requirement to collect 200 per unit per month, that's a tiny fraction of what's occurring every day in each unit. And the third piece is that there's the concerns with the Hawthorne effect, that secret observers may result in employees temporarily changing their behaviors when they know they're being watched. So Leapfrog appreciates that many electronic compliance monitoring systems are rather early in their deployment and can be rather expensive, but Leapfrog has experience with holding hospitals responsible for and accountable for adopting health information technology. So for example, with computerized physician order entry systems, Leapfrog saw that the holding hospitals accountable for the adoption of those improved both the accuracy of the systems as well as the costs. And so Leapfrog believes that a similar trajectory is possible with electronic compliance monitoring systems. Leapfrog also requires in either scenario, either the scenario of electronic compliance monitoring or secret observers, that facility use coaches to monitor hand hygiene performance. That way they can monitor things like technique and missed opportunities. The feedback domain is pretty straightforward. It focuses on who receives feedback about hand hygiene performance, the frequency of that feedback, and what's being done with that feedback. Leapfrog does require as part of this domain that senior leaderships, the medical executive committee, the board of directors receive regular feedback about the hand hygiene performance, and regularly is defined as at least twice a year. Leapfrog also requires that senior leadership be held accountable for hand hygiene performance, either through their performance reviews or their compensation. And finally, the 5th domain focuses on culture. And as I think we all recognize, culture begins at the top of the organization. The feedback we've gotten from facilities is that they see this as actually as the easiest domain of the 5 to meet. And so we sort of refer to it as the free square in bingo. And hopefully others see it that way as well. So there's 2 elements here that are required. One is that the CEO, the chief medical officer, and the chief nursing officer need to make a visible commitment, either written or verbal, each year, committing to the importance of hand hygiene. So this could be a town hall call, this could be an email, this could be celebration of Hand Hygiene Week, but we want some sort of visible commitment from leadership around hand hygiene. And the second element is that the facility invites visitors and families to remind healthcare workers to practice proper hand hygiene. So the Leapfrog group was founded on the idea of transparency, that the information that they collect about hospitals' quality and safety practices would be made available for those who are using and those who are paying for the healthcare system. And it's no different than with Leapfrog's hand hygiene standard. So in the 2021 Leapfrog Hospital Survey and the ASC Survey, Leapfrog will be publicly reporting facility performance based on all 5 domains. Leapfrog does use a cell phone bar methodology for reporting. So achieving the standards is 4 cell phone bars, considerable achievement is 3, and down from there. Leapfrog's scoring algorithms, so in terms of how we decide what performance category to assign to each facility, these scoring algorithms are fully transparent. They're available on Leapfrog's website. The one noted difference that I will highlight is between achieve the standard and considerable achievement, really focuses on the monitoring domain. So for a facility to achieve the standard, they need to be collecting the 200 observations per unit per month. To receive 3 bars or considerable achievement, the focus would be getting 100 observations per unit per quarter. And a hospital can achieve the monitoring domain either with secret observers or electronic compliance monitoring systems. So Leapfrog's other public reporting initiative, the hospital safety grade, will be using a hospital's performance on the hand hygiene standard in both the both the fall 2021 and the spring 2022 hospital safety grades. Leapfrog did recently put up for public comment a proposed scoring structure for how those performance categories would get converted into points. So in terms of next steps for hospitals, where do we go from here? Well, where do we go from here, excuse me? The intent is to keep the standard stable for a while. This will allow facilities the opportunity to set goals based on the standard. Leapfrog does offer a number of opportunities for public comments. So each year, Leapfrog does have a public comment period in the fall where facilities can respond to Leapfrog's proposed changes for the following year. All of those comments are reviewed and appropriately shared with the expert panel. And then we review and re-review the standard. So all the comments that have been received to date, including the letter from APIC, have been reviewed by Leapfrog, have been shared with the expert panel, and we continue to review and re-review the elements that are part of that standard. So we appreciate the feedback. Please continue sharing the feedback, and we will continue to work that in as appropriate. And where I think there's a real opportunity for infection prevention leaders is really around Leapfrog's focus on transparency and publicly reporting facility performance. We believe this actually reflects a key opportunity for infection prevention leaders to use this as a discussion point with their senior leadership about the resources that are needed to accomplish a best practices hand hygiene program. And for those of you who are interested in learning more about specifically the sample size requirement that Leapfrog has outlined by Leapfrog's expert panel, we have provided a list of references here. And with that, I'm actually going to turn it over to Sylvia to talk a little bit about the Joint Commission's approach to hand hygiene.
Thank you, Matt. That was excellent presentation. I really appreciated all the detail you went into. As an infection preventionist, I first started seeing the beginnings of Leapfrog over 20 years ago when I was working on my MBA. And I was really excited about what your organization was planning on doing. And I really, as I told Matt earlier in our discussions, it really has come to fruition. It is taking what is happening now, today, and trying to implement those important things to support infection prevention and control. And really appreciate that you came before me, because what I'm going to be talking about is the Joint Commission hand hygiene standards, which are a little bit different and have quite a different process, and sometimes are not as specific, and actually always are not as specific as what Matt has presented. So I'm going to go ahead and get started. And the first thing I always have to do is talk about the Joint Commission disclaimer. This is our internal policy that these slides are meant to be cue points, and they are only cue points and are not representative of the entire presentation I will do today. If you would like to use these slides, we do that. You can make a personal request to myself or the Joint Commission, and we will see about having you be able to use the slides in another venue. But other than that, please do not distribute them other in PDF format. So I'm going to start with the Joint Commission standards and national patient safety goals. And I think Matt did a great job in setting up the dichotomy between our two organizations. So like Leapfrog, the Joint Commission standards are based on a review of the literature and what is happening in practice at the time the standards are being developed. They also include technical advisory panels and feedback from the public. So really important to understand that the processes of developing them sound like they're pretty similar. Now, one of the things that I think is important that many people don't realize is the Joint Commission standards are not regulatory. So we are not a regulatory agency. We are an accrediting organization. We are the largest accreditor in the United States. And because of that, I think many infection preventionists think that we actually have the force of law, and we don't. And I'm hoping that when you walk away from this presentation, you're going to see some of the differences and the importance of we have given organizations choice. And that's very important to the Joint Commission's mission and vision, which is that organizations consistently strive to improve the quality of the care that they provide, and they provide a safe environment for their patients, their visitors, and their staff. And in doing that, we understand that organizations need to have flexibility in their choices. So the standards, as we go through them, are written very generally. So for example, we require that organizations, no matter which kind of program or what kind of setting, whether you're an ambulatory care setting or you are a hospital or a nursing care center, or you're providing home care, you have to have a goal to improve compliance with hand hygiene guidelines. Now, I think that's important, right? Matt, in his presentation, was talking about purely improving compliance with hand hygiene. The Joint Commission is looking at improving hand hygiene in compliance with hand hygiene guidelines. So there's a lot of ways to do this because there's a lot of hand hygiene guidelines out there and a lot of different things that you can focus on. Now, we are prescriptive in some things, and that's the next standard, which is the organization using standard precautions. And this is one that over the last 3 years since I've been at the Joint Commission, I've tried to put the word out. When the Joint Commission talks about standard precautions, we're not talking about universal precautions, the term that was used when the bloodborne pathogen standard first came out. And then the development of standard precautions from there, which is treat everyone as if they're infectious. We are talking about standard precautions as a concept and recommendations that was presented by the CDC in a core practices for all healthcare facilities document. And we have provided you with a link on this slide to that core practices. As part of standard precautions, when and how hand hygiene should be done is outlined in the core practices. So we do expect you to follow those core practices, meaning the standard precautions section. We also expect you to have a method for communicating responsibilities for hand hygiene. But we aren't prescriptive about how you need to do this with your staff. We do tell you that you do have to include visitors, patients, and families as far as their responsibilities of hand hygiene. And most organizations do this by posting signage about, hey, don't forget to wash your hands at their entrances. They tie it to respiratory etiquette in their posters about reminding about hand hygiene. And they also may do what Matt talked about, which was encouraging their patients to speak up. And that's the Speak Up campaign. Now, the other part of the Joint Commission standards is just making sure that you are using your alcohol-based hand rubs in a safe way, that you are storing them, handling them, installing them in a way that would not create a risk to your environment, particularly with as far as risk of fire. So there are very prescriptive standards that talk about where and where you cannot put alcohol-based hand rubs to ensure that you are meeting those safety standards. So for example, there are some standards that talk about where you can put them in and where you cannot put them in and capacity, which we know that has been a challenge for some organizations. I myself, when we were installing our alcohol-based hand rub in our newest building, that's about 5 years ago, when I was out in practice, we had planned alcohol-based hand rub containers outside of every room and then in every room as the Leapfrog standards would require, the updated standards. Now, the issue was when we had a capacity issue. We were over our limit as far as 10 gallons in a smoke compartment. And so we ended up having to really negotiate, where are we going to put the containers? So there are some limitations, and I'm hoping that Leapfrog is going to be looking at that when it is a fire code issue. Hopefully the feedback has been given to Leapfrog from you all in the field. I think it's also very important that we take, as infection preventionists, that next step of ensuring that we're giving good feedback. Right? The other standard, and it's actually not a standard, it's a national patient safety goal. So the Joint Commission has standards, and then they have national patient safety goals. These are key issues where we want to ensure that organizations understand the importance of a topic and are prepared to provide a safe environment related to that topic, or a safe process related to that topic. Now, we in our standards and our national patient safety goals are not always prescriptive. But what we are asking organizations to do is follow a process to get you to the best possible process. And so in order to do that, the national patient safety goals focus on complying with CDC and WHO hand hygiene guidelines. And we require that you implement a program that follows category 1A, 1B, and 1C of either the CDC and or current World Health Organization. Now, why would I say and or? Because in some cases, people have chosen to use elements of the CDC guidelines and elements of the World Health Organization, and we don't want to penalize those organizations because they're trying to do the best practices in general. We also require that organizations set goals for improving compliance with hand hygiene guidelines. And this has been misunderstood, and I was able to speak to the group at APIC last year, and actually as an audience participant at a GOJO Symposium 3 years ago now. And it's really important because I think as infection preventionists, we often get stuck in that perfect is the enemy of good. And so when we're looking at improving compliance with hand hygiene guidelines, we're thinking of everything, the world. And so rather than trying to fix certain elements, we end up trying to fix everything at once, and we lose that focus. And so the Joint Commission standards are set goals for improving compliance with hand hygiene guidelines. You pick the part of the guideline. Now, it's interesting because Leapfrog has focused on hand hygiene itself and making sure that you have the product available, which are actually covered in infection control standards. However, from a goal standpoint, you get to choose the elements. You get to choose how you're going to monitor and how you're going to improve. And that's the third part of the National Patient Safety Goal. The expectation is that you will improve compliance with whichever hand hygiene guideline you have established your goal to focus on. Finally, in the Joint Commission standards, so we went to the standards, then we went back to the National Patient Safety Goal, and then back to a standard. In the Joint Commission standards, it is expected that the organization will evaluate the effectiveness of their infection prevention and control plan annually and whenever significant changes occur with regards to their infection prevention and control goals. So our expectation is that you are not just putting out a goal there and saying, hey, we're going to improve our hand hygiene, or we're going to work on getting rid of those artificial fingernails for direct care providers, but also looking at what you planned. Did you implement it, and did you improve? That lends itself to what Matt said earlier about most organizations are now reporting 95 plus compliance with hand hygiene. And so this is really asking you all to move up the mark. If you're reporting 95% compliance, it's time for a change. Either you're looking at something that you fixed completely, or you may need to be looking at how you're collecting the data. And I think Matt brought up some really good points about the validity of some data. So whenever I talk to infection control groups, because our standards are so general, it's very important that IPs and anybody who is using the Joint Commission standards know that it's about your approach. It's not about our standards. It's how you decide to implement those standards. And when it comes to infection prevention and control, we ask organizations to follow a standardized approach that will get you to the right answer for your organization. I'm sure most of you have seen this. If you haven't, you need to talk to your accreditation manager and ask them to pull a copy of Perspectives, that's the official newsletter of the Joint Commission, and read through that hierarchical approach that was presented there. Now, I will tell you, 2.5 years later, after providing this in Perspectives, I'd like a do-over. So at the very bottom, it talks about the organization's infection prevention and control policy. So many times, infection preventionists look at this hierarchical approach and they think, okay, I'm going to follow this approach, and at the end I have a policy. And you don't. Everything does not require a policy. There are some things that do, but many things that don't. Instead, what that should say is organizations' infection prevention and control processes, procedures, or policies. Only if you see a D with a circle, in a circle, is documentation required of the Joint Commission standards. Otherwise, you can explain, here it is on a poster, here's what we do, or here's our process, and talk us through it. Really important to remember, not everything requires a policy. Now, I do want to talk about these in a little bit of detail related to hand hygiene. And this is a slide that you've probably seen multiple times if you've heard me talk before, but I want to focus on what's important for the infection preventionist to know about the implementation of regulations related to hand hygiene, because I think there's some myths out there. Do you need a separate sink for hand hygiene in your decontamination room? And the answer is maybe. What does your local state building code require at the time that your organization built that decontamination room? Now, if you're building new, for sure, you need a separate sink. But if your organization is 30 years old, you really need to look back at when was the last time that area was upgraded and what were the code requirements then. But if you don't have a separate sink, well, OSHA says that you need to do hand hygiene in a sink with soap and water if there was a likelihood of contamination with bloodborne pathogens. Right? With decontamination areas, we often think of that. OSHA has put out interpretive guidance. And OSHA says if you don't have a sink, you can remove the gloves, use the alcohol-based product and or wipes, and then step out or go somewhere where there is a sink as soon as it is available. So it's very important that when we see something that we think is a requirement, that we actually dig further. And we make sure that we are giving our organizations the best recommendation with which to make decisions based on hand hygiene. So the other thing I want to make sure that you are aware of is CMS has been collaborating, and that's one of our hierarchical steps, CMS requirements. CMS has been collaborating with the state survey agencies and with accrediting organizations like the Joint Commission. And as a group, last March, we put out a statement that said, we support CDC Clean Hands Count campaign. Now, what does that mean? Well, many healthcare providers have gone to the CDC website in the past when there was a site for the general public and there was a site for healthcare workers. And they didn't realize that they were on the public website, not the healthcare worker website. So it's really important that organizations understand that alcohol-based products are the preferred product for hand hygiene in the healthcare arena, except when hands are visibly soiled, or if you are having an outbreak of C. diff, and I've included norovirus here because sometimes those alcohol-based products aren't effective against norovirus. So those are two situations when CMS, in collaboration with their state agencies and accrediting organizations, said best product is an alcohol-based product unless these situations occur. In order for you to know what CMS and your state survey agencies are surveying to. There are 2 infection control worksheets that are available. I've given you the links for these. One is for ambulatory centers, and the other one is for hospitals. Now, they do have additional self-assessment tools, for example, for nursing homes that you can look at, that are even more a little bit more detailed than these. But if you want to know what accrediting organizations or your regulatory agencies are looking for, this gives you a good idea of what you need to have in place from a compliance standpoint. We also require in our standards that organizations follow manufacturer's instructions for use. Many organizations have gone above and beyond what the manufacturer requires, and that's the best practice. WHO and CDC recommend a way for you to use alcohol-based hand rubs or to do hand hygiene. But the manufacturer's instructions is what you will be scored to unless your policy says something more strict. So how do you resolve those issues, right? How do you have your employees follow the manufacturer's instructions for use at minimum and then say, this is the preferred way we would like you to use an alcohol-based hand rub, or the preferred way that we would like you to do hand hygiene? You would meet the standards if you say, follow manufacturer's instructions for use. We also want to remind organizations that we do expect that organizations are going to follow expiration dating on those containers of alcohol-based products or any other product. And then it's very important because of the COVID pandemic that there were suppliers who made products which may not have expiration dates. We've sought clarity from the FDA, and the FDA has explained that those products that do not have an expiration date really you really should not be using them after the public health emergency is over. And you can go to the FDA website to find more information about expiration dates. The next level in the hierarchy is evidence-based guidelines. And everybody gets a deer in the headlight look when the surveyor says to them, so tell me what evidence-based guidelines you use. Well, the Joint Commission is pretty prescriptive here. You have to use CDC or WHO hand hygiene guidelines. And if you are doing that, you can check off that you are using an evidence-based guideline because it's a requirement. Some states have incorporated by reference into their licensing, for example, Illinois, that organizations must follow a particular CDC guideline. In this case, for Illinois, it's the CDC guideline for hand hygiene in healthcare settings from 2002. So it's a little bit out of date, and we recognize that. Evidence-based guidelines required by Joint Commission standards are those CDC and WHO hand hygiene guidelines. Now, you remember, if you were at my presentation last year, that there aren't very many differences. So we're not looking at you to pick one or the other, but to pick the important parts for your organization. We also require that you follow standard precautions. And this is that section that I referred to earlier, that you as an organization, if you are undergoing Joint Commission accreditation, are supposed to be following. This provides the indications of when hand hygiene should be done. And so that is an expectation during survey. So what's the bottom line? What do you need to do to be compliant? And I tell people this all the time. We have a lot of questions asked. How do you remain compliant? You follow the hierarchy to meet the infection control requirements. And that may be different whether you're in Hawaii, California, Chicago, or New York City. It's going to be different depending on where you are and what choices your organization makes. But the bottom line is that you have to follow regulatory requirements, both for your sink installation, your soap, and your alcohol-based hand rub. How you install it, how you use it, how you dispose of it. As a baseline for your hand hygiene program, you have to follow CDC 1A, 1B, and 1C recommendations. And you have to require staff to perform hand hygiene when indicated by standard precautions. You have to implement activities and interventions that you identify in your own hand hygiene program. So if you wrote it in your program, if you wrote it in your plan, if you wrote it in a policy, the surveyor is going to expect you to follow it. So be careful what you write, because you will be held to the level at which you have said you are going to do this. Unless hands are visibly soiled, alcohol-based product is the preferred product. And we talked about that a minute ago. You need to make sure you have a way to communicate responsive hand hygiene to your patients, your visitors, and their families. And you have to choose which hand hygiene guideline or guidelines you are going to work to improve. Work towards that improvement, develop a plan, implement your plan, monitor that you are doing it, and then evaluate your plan. I think it's really important here that you know that when Matt talks about monitoring, it's very different than what the Joint Commission is talking about as far as surveillance. So IPs, we have found, use the term often interchangeably, and others outside of the Joint Commission use the terms interchangeably. The Joint Commission has a glossary, which includes the definition of surveillance. Surveillance is the systematic process of collecting data, analyzing it, and then using it to improve processes. Monitoring, on the other hand, which is recommended by the CDC as a 1A, 1B, 1C recommendation, it's in that list, includes walking on the units, seeing someone who's not washing their hands, saying, excuse me, but I noticed you didn't do any hand hygiene. This is why you need to do it, and providing them with feedback. So the importance there is that the Joint Commission standards really want you to be providing that monitoring and feedback all the time, not just as part of your surveillance. And I think that really gets to that ethical issue that Matt was talking about. We need to make sure that we are holding each other accountable for keeping patients safe. And we all know that hand hygiene is key to that, keeping patients safe. Now, I do want you to know that the infection control standards have not been updated in a long time. And I know I've been an IP for 35 years, and other than the National Patient Safety Bill updates, there really hasn't been a lot of movement in the infection prevention and control related standards. The Joint Commission is in the process of revising the infection control standards. So we kicked off the process about 3 or 4 months ago. The initial review is happening now of what we will actually be revising and the domains that will be included. I'm very, very excited about this, since I came to the Joint Commission 3 years ago with the hope of being able to clarify for everyone in the field what are the requirements, what really is a requirement, and what's an option. That process will take about 1.5 years to 2 years until you are expected to fully implement those new standards. In that next about year, we have started the literature review. We will be asking for technical advisory panels to meet on the different subjects, including hand hygiene. For all of our standards, there is a public comment period. Please, in the next year, start looking for those public comment periods. Just like Leapfrog always welcomes your comments and concerns, the Joint Commission does too. We often hear from organizational leaders about their concerns related to Joint Commission accreditation. Be part of that movement. We want to know what your pain points are. We want to know what your questions are. And making sure that your organization leaders who may be represented on an advisory panel are bringing this forward is really important. Finally, if we are going to, and we will be including the new updated standards for deeming purposes, it will require a final review and approval by CMS. So once that process is through, we hope to have much more clear hand hygiene standards for you to follow. And probably not as prescriptive as those that Matt presented with a minimum number, but maybe something more general that says that you have to provide statistically significant data in order to make change. That's my hope anyway. So stay tuned. I have provided my email to the audience, and if you have any questions, I am always available. I have 2 peers at the Joint Commission who are also certified infection preventionists, and we hope that you will contact us with your questions. And with that, I'm going to turn it back over to Megan.
Thank you so much, Matt and Sylvia. I really appreciate appreciated hearing from both of you about what's expected from each of your organizations. And we have about 10 minutes before we start the question and answer session with the audience, but I wanted to take the opportunity to allow for some dialogue between the two of you. So I have a couple of questions. First, Matt, you mentioned that Leapfrog, you've made a lot of changes to your hand hygiene portion of your survey, and that you're going to sit tight for a little while and kind of let us adapt and adapt to those changes. And Sylvia, you mentioned that the Joint Commission is looking to revise infection control standards. So as we look to the next 5 to 10 years, what do you see as the most critical change that's needed?
And so if you don't mind, I'll go first. Yeah. So I think Matt really highlighted something important, which is resources. We have seen with this public health emergency that it's not just, you can't just expect your IP to be out there collecting data on hand hygiene, right? That cannot be their primary function. And the efficient and effective way to collect data is so important. And that's really about providing resources to the infection prevention and control program and prioritizing those resources.
Yeah, Sylvia, I think you're so spot on, right? I mean, I think, and I didn't do a great job of highlighting this in my presentation, but I mean, the expert panel that we worked with was very clear with Leapfrog that they feel like facilities have under-resourced hand hygiene, right? So the push to collect more observations, the push to ensure that infrastructure is in place is really all sort of formed around this idea that we need to do a better job of resourcing. In terms of a future vision, I mean, I think at least from the Leapfrog perspective, I think it sort of sees what role can health information technology play, right? So as we talk about like electronic compliance monitoring systems, I'm sure there's other innovative technologies out there. Where can we go with that? How can that sort of replace the human beings that are needed to do the work today, to really allow human beings to focus on the things that are important? So I'm excited to see where health information technology can take us around hand hygiene.
And just to add to Matt, I think my vision for 10 years from now, the infection prevention is using that data to do infection prevention. That their focus is on the prevention aspect and not on the data aggregation and collection part of it. Giving them the skills and resources to really look at this really, really important topic that we know not just saves lives, but also saves organizations money.
Exactly. So another question for both of you is, obviously you're both patient safety organizations, and we know that healthcare over the last decade or so has moved towards transparency. And one of the differentiations that I heard between the two organizations is really the C-level accountability. So, that is in the Leapfrog standards. Does the Joint Commission hold the C-suite accountable? And if so, how do you do that?
Absolutely. And so we have leadership standards that organizations must follow, right? And so for example, when I talk about regulations, if an organization doesn't follow their regulations, leadership is held accountable. It's a leadership standard that is scored. When an organization does not provide resources or they haven't trained their employees, that is scored under a leadership standard. So even though sometimes it feels like it's an infection control responsibility, ultimately it is the C-suite who is responsible. And when we find issues that are systemic, it usually results in a leadership finding.
And Sylvia, just for my own, are the leadership standards part of the infection control standards, or are they something that's sort of in parallel to?
They are part of the accreditation standards. So organizationally, organizations must meet all of the accreditation standards in order to be fully accredited. So they tie together nicely, right? Yes, we are in chapters to organize, but ultimately that leadership chapter is oversight over the entire process.
Okay. Yeah, and I think the only difference is just how we've framed it with Leapfrog is that we've made it sort of specific to hand hygiene, and right, and that accountability is not unique just to hand hygiene, right? I think, Leapfrog expects that in many different areas of patient safety. We've just sort of called it out in specific relation to hand hygiene. So, but it sounds like both organizations are sort of saying the same thing, which is that senior leadership needs to be engaged and held accountable for, patient safety, which is ultimately what we're, I think, trying to communicate.
Yes.
Thank you. And is there any concern as more healthcare facilities look for ways to collect meaningful, statistically significant hand hygiene data? Would there be any concern about what they find? And if the Joint Commission, if they've uncovered something that they're concerned about or they don't like it, is it possible that the Joint Commission could then maybe not applaud them for the work that they're doing and perhaps, ding them, as we like to say? Sylvia, can you share anything about that?
I absolutely can. And it wasn't included in my slide, but I am an ambulatory surveyor. So I actually go out and survey organizations. And I think the important thing to realize is we are hoping that our accredited organizations, and we expect them to be improving the quality of the care they provide. Does that mean that they might identify that their actual hand hygiene performance, if they use an electronic system, and I know this from other organizations telling me, right, is somewhere between 18 and 28% to start? That is not unusual when you start an electronic system. However, what we do expect to see is improvement. You define the improvement. You decide how you're going to get yourself up to hopefully 90%, right? It's hard to get to 100, but really to improve it. The Joint Commission should not be scoring you. Your surveyor should not be scoring you on an issue that you have identified, and you have a real process that you have in place to fix and does not create an immediate hazard to your patients. Your hand hygiene rate is low. We expect you to be working on it. That's good quality. That's performance improvement. We want to see that.
Excellent.
And that's interesting to hear, because I sort of, the way Leapfrog at this point has not set out a standard for what compliance rate hospitals need to have, or facilities, or ambulatory surgical centers. And there's been some internal debate about that, right? Like, should we be setting some sort of threshold? I think the concern is, if you set some sort of target, does that create an incentive for poor data collection, right? And are there incentives for people to game things because all of a sudden now Leapfrog or the Joint Commission says we need to have, a 90% hand hygiene compliance rate. And so I really like the way you framed that, Sylvia, around quality improvement, right? And that's the goal, right? Is to improvements and to use data for improvement, as opposed to necessarily trying to hit some magical number.
Yeah, I think it's really important for organizations to keep in the back of their mind, we are looking at your processes. It's really about the processes, right? We aren't going to score you if your surgical site infection is 50%. We're going to look at your process, that how are you working to get that number down? If you have identified a problem and you don't have a process to fix it, that's when the scoring comes in. We want to see real progress. And I really appreciate that Leapfrog didn't set a number, because you're right. We see this when we have put out a number, people will manipulate their data to match that number, and that is not the goal here. So thank you.
The audience questions are flowing in. So I think with that, let's turn it over to the audience questions. So looking forward to those.
Thanks, Megan. Thanks, Sylvia.
Yep, thanks, Megan and Matt.
Welcome back, everyone. As we start the audience question and answer session, I just want to remind you that we will send out the slides so that both of the speaker slides will be made available to attendees. That is a very popular question in all of the sessions, so we'll address that head on. The first question, Matt, that I'd like to ask from the audience is if Leapfrog knows that the electronic systems are in early development, why the hard push to spend the money now for the systems, especially in light of all of the costs associated with COVID that hospitals have had to assume?
Yeah, so Megan, thanks for that question. And this one, comes up, I think, quite often around Leapfrog's monitoring domain and the different paths that Leapfrog lays out. So as indicated, and just to remind folks, Leapfrog does actually offer two paths for monitoring. One is direct observations using secret observers. The other option is to employ and install electronic compliance monitoring systems. Now, why Leapfrog is pushing on this is, it can appreciate from its past work with, urging hospitals to adopt computerized physician order entry systems and other health technology, that these systems are early, but the way that we improve the systems is getting hospitals to adopt them. And Leapfrog firmly believes that as more hospitals adopt these systems, the systems will get better and the cost of the systems will come down. So there are two options. Electronic compliance monitoring is one option, and Leapfrog firmly believes that starting to get these systems implemented will improve both performance and cost.
Thank you, Matt. So another question for you. Does Leapfrog have plans to be more inclusive of the Centers for Disease Control and Prevention guidelines as compared to World Health Organization?
Yeah, so just to clarify, Leapfrog standard is actually adapted from the WHO self-assessment framework. But Leapfrog is not prescriptive with what an individual facility, whether that be a hospital or an ambulatory surgery center, in terms of if they follow the WHO 5 moments, the CDC's guidelines, or if their institution uses some sort of blend of the two. So Leapfrog is not necessarily trying to enforce or reinforce WHO. It simply used that as a framework for measuring facility performance in this area.
And Sylvia, can you comment and just remind us again what the Joint Commission does or does not require related to World Health Organization versus CDC?
So from a regulatory standpoint, if your state requires a specific evidence-based guidelines, so for example, in Illinois, we are required to use CDC hand hygiene guidelines. If that's a regulatory requirement, then the expectation would be that you use CDC. You can, however, add in World Health Organization. Otherwise, it is freely your choice to determine which guideline you would like to follow. However, they're very similar. So there's not a lot of differences between the CDC and WHO.
Okay, thank you both. Sylvia, this question is probably specific for you. This person works in a psychiatric facility where they obviously cannot have hand sanitizer readily available in patient-accessible areas. They mentioned that they currently keep hand sanitizer in the nurses' station, and staff may keep their personal small hand sanitizers on their person. And staff is responsible for maintaining it safely. So is that an acceptable practice?
Absolutely, and that's part of why the Joint Commission has leeway on on the standards, which is so that you can get a process that works for your organization.
Okay, great.
And Megan, from the Leapfrog perspective, that's the guidance that the expert panel has given to us as well, is that for behavioral health units, the need to have hand sanitizer dispensers in the unit itself is sort of waived for behavioral health. So yeah, that seems to align. So that's helpful.
Okay, great. Thank you both. Matt, this question is for you. The 2021 Leapfrog Partners Advisory Committee consists of members of industry. And the question is, how much influence did these organizations have in developing the minimal sample size for hand hygiene monitoring? So if you could address that, that would be appreciated.
Yeah. So I'll start with the easy answer, which is none. They actually had no influence over setting the hand hygiene observation size. So just to talk a little bit about Leapfrog's Partner Advisory Committee, this was founded in 2009 to bring key healthcare stakeholders to the table periodically with Leapfrog's management, with Leapfrog's board of directors, to listen and understand what's happening in the healthcare sector. But the Partners Advisory Committee has zero influence over the content of the survey. Everything that went into the Leapfrog hand hygiene standard was either informed by the literature, our expert panel, or sort of the guidance of myself and the team at the Armstrong Institute. So the Partners Advisory Committee actually had zero input into setting the threshold for hand hygiene observations.
Okay, thank you, Matt. Another question for you, Matt. How does Leapfrog respond to the letter from APIC Shea about the hand hygiene criteria? And for those who may not be aware of that letter, could you maybe just give kind of a brief overview and then tell us how Leapfrog responded to that?
Yeah, so if I remember correctly, the APIC letter came in with Leapfrog's public comment opportunities that it offered. And through that, APIC, I think, really had two concerns that they raised. One was specific around the hospital safety grade and how Leapfrog would be scoring the hand hygiene standard in relation to the hospital safety grade. The second concern was about the 200 observations per month per unit requirement that Leapfrog requires for hospitals to fully meet or fully achieve its standard. And APIC did float the idea that the 200 is not necessarily, while it is grounded in statistics, there is no requirement that it be per unit or per month. And that is true, that there is nothing statistically that says it needs to be per unit per month. The per unit per month requirement actually comes from the expert panel and really sort of key stakeholders throughout the industry, that's really best practice for monitoring performance, is to measure at a unit level and to monitor that monthly. Leapfrog has responded back to the APIC letter. I believe it was Nancy who submitted the letter, and I'm forgetting Nancy's last name, my apologies. And a response was offered back to Nancy in terms of those comments.
Okay, great. Thank you, Matt. And as a sort of a follow-up question, because you mentioned the panel and their work on helping to develop the survey questions, will the expert panel for hand hygiene include practicing infection preventionists in the future?
So, Leapfrog historically has been really tried to have sort of a wall between those who are in the hospital doing the work of quality and safety and those who do research in quality and safety. And so we've leaned towards populating our expert panels with those who are doing research, have published on the topic. It's not to say that there's always a clean distinction between those two. For example, I believe Dr. Emily Landon at the University of Chicago actually is in an active infection preventionist role at her institution. And so I think there is some overlap. I would also say that Dr. John Boyce, who is also on our panel for many, many years, led the infection prevention efforts at Yale New Haven. So I think there's a lot of experience there.
And can I just add, Matt, I think I was able to comment on the proposed changes to Leapfrog several years ago when I was in an infection prevention and control position. And I think that's really important for the audience to know is many of these standards that are out there are going out for public comment. And everybody has an opportunity to comment, but you have to be looking for them and you have to be aware and you have to take the opportunity.
So true.
And Sylvia, you mentioned, go ahead.
Thanks for pointing that out,
Sorry,
Sylvia.
there's a lag.
I think it's, and we review each of those comments, and as needed, we take those to the expert panel. So to your point, please use the opportunity to comment. We want to hear what thoughts are. and we read each one and take them into consideration.
And Sylvia, you mentioned that we'll have the opportunity to publicly comment on some new standards that the Joint Commission will be proposing in the next couple of years, as a reminder to the audience.
Absolutely, and we need infection preventionists to be active. Right? Don't just sit back and say, well, I hope somebody says something. If you have a comment or a concern, it's time to put your computer on and answer the concern, or put it in there so at least it's addressed. Because I have been on many of these types of panels, and they go line by line with every single comment. I don't know if Leapfrog does that, but I know that we do at the Joint Commission.
Yeah, we do review every comment that comes in, and we put out public responses to those as well. So that is Leapfrog's commitment, is transparency. And so Leapfrog does review each of those and offers back a response.
Okay, thank you. Sylvia, this question is for you. What is the Joint Commission's perspective on patient-centered hand hygiene?
What's our perspective? Oh my gosh, that you should do it, right? I think we all know that the CDC guidelines have been in effect for a long time. They are patient-focused. They are extremely prescriptive about when you should be washing your hands when it comes to a patient. I think it's really interesting that we get pushback from people on, do I need to wash my hands every time I go into a room? You're going into a patient's environment. Yes, you need to wash your hands. But we do depend on organizations to put that into their policies and enforce those policies. It's all about the patient.
Okay. And this is a question for both of you. So what is your respective organization's definition of secret observers? That's kind of an interesting question. How would you define secret observers? We'll start with you, Sylvia.
So we don't have a definition of a secret observer, and we do not require that organizations use a secret observer. And that's what's, I think, a plus for Leapfrog, right? They've taken a stand and said, you need to use secret observers. We all know the Hawthorne effect exists. It's very well known. I've actually talked to the Center for Transforming Healthcare about it when I came to the Joint Commission, because I was concerned about the role of secret shoppers and the importance of having that in place. And I think what we need to remember is it's about quality improvement. And so how you get your data is as important as the data that you end up with. We can't be prescriptive. Our standards don't allow for it at this point. In the revision of standards, could we have definitions? Possibly, but I think it's unlikely that we would ever get that prescriptive. So really no definition of a secret shopper.
Yeah, and I'll chime in next on that. So Leapfrog, obviously, one of its options for monitoring focuses on the use of secret shoppers or secret observers. Although we don't have a strict definition of what that is or what that looks like. And so we would welcome input and thoughts from the audience and from others around what might be a meaningful definition of that. We've sort of left that up to each facility to determine what is the right way of doing that. But if there's suggestions of how we could codify that into something a little more standard, that would be helpful.
Okay, thank you both. Matt, this is a question for Leapfrog. If the greater emphasis on hand hygiene is due to no real move on healthcare associated infections, why doesn't the number of audits required why isn't it in proportion to the rate of HAIs that a facility has, such as those with a higher standardized infection ratio are required to submit more audits, and those that are obviously doing the right thing, whatever they feel is representative is good. So basically moving to an outcome-based sliding scale, if you will, for the number of observations that a facility has to perform.
Yeah, so that to me is an interesting idea, and we are considering something for that as it relates to electronic compliance monitoring systems. And Leapfrog does have the requirement that even hospitals or facilities that are using electronic compliance monitoring systems do some level of direct observations. And so we are discussing with the expert panel the idea of one criteria or factor going into that decision of how many observations need to be done being reflective of whether the unit has sort of a high compliance rate or a low infection rate, and perhaps adjusting from there. In terms of the number of direct observations, if you're using secret observers, that 200 actually comes from, statistics, and the biostatistician's guidance that we received was that to understand in a statistically significant way the difference in performance between 1 month and another month is actually independent of the number of patients in a unit. And so that's where we arrived at the 200. Leapfrog does offer hospitals and other facilities the opportunity to scale that down for smaller units. But I'll definitely take back to the expert panel this idea of perhaps we should work into that some degree of flexibility for low infection units.
And I just want to add to what Matt just said. I have to tell you, as an infection preventionist, I'm a little concerned to hear that. I'm a little concerned because we all know that HAIs are multifactorial. There's not one thing that results in an infection. If we did, we'd all have the magic bullet and we'd be able to stop all these infections, but we don't. So my concern is, great, your colonoscopy rate is good, or your SIR for C. diff is great. So now you don't have to look at hand hygiene. It doesn't make sense to me. So I'd be a little cautious about saying because you have a low infection rate, therefore you don't have to monitor hand hygiene or provide feedback.
Yeah, the only thing I'll add to that, just as I sort of further mature my thoughts on this topic, is this idea that most of the infections are measured at the hospital level, right? And we're really trying to drive, I think, unit level performance around hand hygiene. So I think it might be a little difficult to make that connection between a hospital's low infection rates as compared to which units are you monitoring for hand hygiene, and just sort of how do you make the link between those two. So that would be a concern that comes to mind.
Thank you both. Sylvia, this question is for you. What are the requirements around hand hygiene in the midst of patient care? So electronic systems only require monitoring entrance and hand hygiene at the entrance of a room. And these are not helpful in the real hand hygiene needs that we know we have, which is hand hygiene in the context of patient care in the 5 moments. And do you have any comments about this?
I do. So this is one, I think I stood up at a GOJO Symposium, in 2018, and said, perfect is the enemy of good. We already know, based on electronic hand hygiene monitoring, that compliance is low. Just people walking into the room is not getting it done. And so I think there's a great opportunity to scale this up. Right? We start with, are you washing your hands when you're coming in and out of the room? And then you start looking at those moments. Those moments are incredibly hard at this point, whether by direct observation or by electronic monitoring, to get it right, to get accurate data. So, even though everybody would love to do it perfectly, I don't think we're there from a technology standpoint yet. And I don't think, as soon as the healthcare worker goes into the room and closes the door, you can't observe anymore. It's this person peering through the window. Can I see what they're doing in there? Did they wash their hands? Didn't they wash their hands? Can you really see? This to me is one that's maybe 5-10 years down the road will be there to be able to really look at those 5 moments. And I don't think we are yet. I don't know if Matt wants to add to that.
Yeah, I mean, the only thing I'll add is, the literature that I've seen and that the expert panel has exposed me to has seemed to indicate that in and out actually serves as pretty good proxies for overall hand hygiene performance. So to your point, Sylvia, we may not be getting every moment, and we may not be able to get every moment perfectly, but if in and out is low, it's probably indicative that the other moments are also not happening.
Okay. So Matt, this is a 2-part question. I'll start with the first part. This person wrote in and said 200 observations per unit per month in a facility with less than 99 occupied beds and small units is an impossible feat. Requiring observations is also challenging, or I'm sorry, recruiting observers is also challenging. Can you share any success stories that do not involve expensive electronic monitoring systems?
Yeah, so let me take the first part of the question because I think that requires a little bit of clarification. So Leapfrog's standard to fully achieve the standard is 200 observations per unit per month. Now, Leapfrog, if you look in the Leapfrog hospital survey, you'll notice there's some tables because what Leapfrog has done, it actually has scaled down that requirement for smaller units, right? So Leapfrog recognizes that to get 200 observations in a month in a smaller unit is actually going to just take more person time than a bigger unit where there's more activity and more patients. So Leapfrog has tiered down the 200 requirement for smaller units, and I would suggest that everyone take a look at that just to sort of familiarize yourself with that. What I would also add to that is, Leapfrog does offer partial credit. So if a unit collects 100 observations per quarter per unit, that would actually get a hospital or a facility to 3 bars, which is a pretty good score on the Leapfrog Hospital Survey. The final thing is you might want to look at the Leapfrog Hospital Survey and how Leapfrog is defining what is a unit. So Leapfrog defines a unit as an area where there is shared staff, i.e. they are scheduled in a common way. They may rotate from day to day. So you may just want to clarify what exactly is a unit in reference to your hospital. The second part of the question is, what have been some of the strategies facilities have used towards recruiting secret observers? I know one of the strategies some hospitals have used has been to go out to floors and recruit folks who work on the floor, whether those be techs or nurses, to serve as hand hygiene observers, is one of the examples that I hear very frequently.
Okay, thank you, Matt. I think this is a question for you, Sylvia, as I interpret it. It says, can we volunteer to be part of the updated pilot for hand hygiene guidelines? I think they mean the new Joint Commission standards that you're working on.
So unfortunately, it doesn't work that way. We will have a technical advisory panel that we will have experts invited to. I can guarantee you, I will make sure there are IPs on that technical advisory panel. But your ability to participate is really on the comment period. However, you all have my email, and if there is something that is really bothering you, please feel free to reach out and tell me your ideas, because I, with someone from the Division of Standards, is doing the first draft right now, and we are happy to include it. So please reach out.
Thank you, Sylvia. This is sort of a follow-up question. Will Joint Commission adapt to Leapfrog criteria?
It's unlikely. Leapfrog and the Joint Commission are very different organizations. It's unlikely that we would go to a Leapfrog type criteria. We tend to be more general and allow organizations the leeway or the ability to decide what is best for their organization within certain standards. We don't normally give a prescriptive number, but we want to see that you have a process to improve. So could it be a little bit more prescriptive? Yes, in that right now, if you look at the hand hygiene related standards, there is no magic number. We don't tell you you have to follow the PI chapter of the Joint Commission, but probably in the near future, we will require something like that. So some basic data collection, performance improvement measures.
Okay, thank you. Matt, this question is for you. Why does Leapfrog insist on direct observation with an electronic system if it has been validated over multiple years? So I think what they're asking is, why do you have to perform direct observation in tandem with electronic compliance monitoring?
Yeah, so there's really 2 primary reasons why Leapfrog requires direct observations in addition to electronic compliance monitoring. So one is technique, right? So the one thing that at least most current electronic compliance monitoring systems don't necessarily monitor is the technique that was used by healthcare workers and others with their hand hygiene performance. So, it's helpful to have some human beings out there making sure that people are following the proper technique when they're using hand sanitizer or washing their hands in the sink. The second reason that Leapfrog thinks this is important is to do some coaching, right? So if someone misses an opportunity to do hand hygiene, it's great to be able to have someone go up to that person and say, hey, Matt, we noticed you walked into Mr. Jones's room and you didn't wash your hands. Just to remind you, when you enter a patient's space, the expectation is that you do that. So just as a reminder. So those are really the two primary reasons, is sort of feedback on technique and feedback on missed opportunities.
And if I can add to that a little bit. So as someone who's done electronic monitoring, right? Lots of electronic monitoring done at my previous organization. And I think it's important. Number one, I want to talk a little bit about that 200. How long or how many times does somebody go into a room that is 200 really an unattainable, achievable goal in a month? Right? If you just look at how many times your staff goes into a room, even if they only go in once every 4 hours to check on the patient, in a day, you're going to have 24 observations of one person going in. So, to me, that doesn't seem like a lot of numerically to get 200. It's really quite low compared to how many times your staff are probably going into the room. But then the second thing is, sorry. That's okay.
Continue, Sylvia.
So the second thing is, why do you need to do direct observation or include direct observation? And my take on that one is, how do you decide what you're going to improve? It's great to have the number. You did it. You achieved 60% compliance, but what is the issue that you are trying to fix? How do you know what that is without more information? Just a number is not going to provide you with enough information to do real performance improvement, as with any problem that you're trying to solve. Sorry, Matt, go ahead.
Yeah, all I was going to do was reinforce the point you were making about the 200 being actually a very small percentage of the total hand hygiene opportunities that exist and go on every day in every unit of every hospital, right? That 200 is a tiny fraction of what actually happens in a unit. So I was just going to reinforce that point.
Okay, thank you. We're down to 2 minutes for our question and answer session, so we'll try to get a couple more in. The first is, have you identified any concerns with fire codes and alcohol-based hand rub quantity when dispensers are located at entrance and inside the patient room?
So I don't know if that's for me, but our surveyors do go out and look. That is not a frequently stored standards, because most of your engineers know about the requirement to have a restricted amount of combustible in the smoke compartment. And then most organizations are aware of fire code, but also your installer is usually aware of what the fire code limits are. So we don't see that a lot.
Okay. And then we may just have time for one more question. Matt, does Leapfrog intend to provide additional resources to support organizations in reaching hand hygiene goals? And do you intend on reporting, scoring organizations separately on hand hygiene compliance?
Yeah, so let me take the second part of that question first, just in terms of time. So as noted, at this point, Leapfrog has not set any sort of magical target for hand hygiene compliance for facilities. At this point, Leapfrog's still really focused on a facility's process in terms of making sure it's monitoring, giving feedback, having the correct infrastructure in place. It's not to say that at some point in the future, Leapfrog may decide to do that, but that's at least not in the short-term horizon. In terms of the resources that Leapfrog does make available, Leapfrog does have a series of town hall calls it offers to hospitals, and we would welcome hospitals to join those for more information.
All right, thank you both. Really appreciate it. And thank you to all the great questions that were submitted. This was a really great session. Thank you so much.
Great, thank you.